Hello and welcome to today's webinar on Alarm Fatigue Review of Evidence and Management Strategies, Part 1. My name is Joe Catino and I am a trauma critical care surgeon and director of the Trauma Intensive Care Unit at Delray Medical Center in Delray Beach, Florida. I am also sit on the Society of Critical Care Medicine's Surgery Section's Patient Safety Committee. A recording of today's presentation will be available on Society of Critical Care Medicine's YouTube channel within 3 business days. Please take advantage of this resource to further educate your colleagues. The webcast today is brought to you in collaboration with the Surgery Patient Safety Committee at Society of Critical Care Medicine. Now for a bit of housekeeping items. There will be a question and answer session at the end of our call. If you have a contribution or question, please type it into the question box located on your control panel. Questions will be addressed at the end of the session. There will also be a couple of poll questions that show up during the presentation. Simply click on the answer that you wish to select. Now I'd like to introduce our presenters for today. Dr. Maria Cvach is a Director of Policy Management and Integration for the Johns Hopkins Health System and a Clinical Safety Specialist for the Johns Hopkins Armstrong Institute for Patient Safety and Quality. Dr. Cvach has extensive experience in cardiology, intensive care, and progressive care nursing. Her research and translation of evidence has focused on alarm management strategies for hospitalized patients. She has published numerous articles on alarm management and patient safety. Dr. Cvach currently chairs the Association for the Advancement of Medical Instrumentation's National Alarm System Steering Committee. She has presented nationally and internationally on her work. We also have Dr. Bradford Winters. He is an intensivist and anesthesiologist at the Johns Hopkins Medical Institution. His research interests are in the patient safety and quality, especially prevention and responding to patient deterioration on general hospital wards. They have no relevant financial disclosures. Now I'd like to turn the program over to Maria and Brad.
Thank you, Joe. And first of all, I want to apologize to everyone that my voice is a little bit scratchy. I'm recovering from a cold, so I'm going to try to hang in there, and hopefully you'll all be able to understand me. So the purpose of our lecture today is to discuss clinical alarm hazards. We're going to be reviewing current evidence related to alarm fatigue. We'll identify gaps in knowledge and where more research is needed. I'll be reviewing the 2014 Joint Commission Alarm Management National Patient Safety Goal, and we'll also be talking about alarm management strategies that you can use today. Medical devices sound alarms 24 hours a day, and many times for non-actionable reasons. The purpose of clinical alarms is to enhance safety. They alert us when a patient's condition is deteriorating or when a device is not functioning properly. A perfect alarm system would never miss a clinically important event, and that means it would be 100% sensitive. And it would also never alarm when there's no clinically important event, and that means it would be 100% specific. But by design, alarms are highly sensitive so that they don't miss any important events, but their high sensitivity is achieved at the expense of specificity. And there are a lot of false alarms which can lead to alarm fatigue. At Hopkins, we've been investigating the problem of alarm hazards since 2006. When we started our initiative, we averaged about 350 alarms per bed per day. And as you can see on this chart, monitor alarms occur in a hierarchy, and the bulk of alarms are categorized as low priority. With so many low priority alarms occurring, it's easy to understand how high priority alarms could be missed. Alarm hazards has become so much of a patient issue. The ECRI Institute has labeled it as the #1 technology hazard for 4 years. And it's been at the ECRI Institute's top 3 list since inception of the list in 2007. The Association for the Advancement of Medical Instrumentation, also called AMI, has tentatively defined alarm fatigue as follows. a condition that occurs when a user is desensitized by the presence of excessive and/or false alarm signals and no response to the alarm occurs. Staff become overwhelmed and desensitized to alarms, and it becomes white noise, and essentially a response is not elicited. There are unintended consequences from alarms. The negative impact of noise on patient healing has been described in research evidence. Some of the effects include delirium, cardiovascular effects, and effects on the immune system. Staff may be distracted by alarms which lead to mistakes. Additionally, staff describe working in noisy environments as leading to their development of headaches and stress symptoms. Families lose trust in us when we do not promptly respond to patient alarms, even though the alarms may not necessitate prompt action. And the negative impact on hospitals from missed alarms can result in litigation and substantial risk management costs. Alarm hazards, as you can see here, are quite complex. Missed alarms and bad outcomes may result from a combination of many different things, such as not setting alarm limits properly, programming errors, too many alarming devices, low specificity resulting in frequent false alarms which desensitize the staff, unclear alarm responsibility by staff, large units with the inability to hear alarms, especially with room doors closed and no backup plan for alarm escalation, and competing staff priorities, because we all know that staff have many, many important things to do besides address alarms. And so that leads us to our first poll question. Please answer the question while I turn over the lecture to Dr. Winters, who will address alarm fatigue evidence that our small group recently reviewed while doing a systematic review.
Thank you very much, Maria. Hi, I'm Brad Winters, and as soon as folks have a chance to finish up with the quick poll, as Maria said, we will be moving on to talking about the evidence in the literature that the FCCM Alarm and Alert Fatigue Task Force has recently completed a review of. And if we look at our quick poll, looking at the kind of results that we're seeing amongst our listeners, there are too many medical device alarms in my work setting, and it would appear that that is receiving a resounding an agreement. 90% of folks either strongly agree or agree, and virtually nobody, only a handful of folks disagree. Clearly underscoring the fact that this is a real-life workplace experience that everybody has been dealing with. So, what does the evidence say in terms of the ability to reduce alarm fatigue? So again, what we're going to be doing is going through a little bit of a quick ride through what the Alarm and Alert Fatigue Task Force was able to discover during a systematic review of what the literature suggests might be some strategies that we can use moving forward in terms of trying to reduce this patient and staff harm. So our systematic review focused on several key questions. Our primary question was, what interventions have been attempted and resulted in the success of reducing alarm fatigue? That is, potential strategies that either could be deployed or implemented immediately, right now, or in the near future. We also looked at a couple of secondary questions. For example, what are the negative effects on patients and families? What are some of the balancing outcomes, that is, the unintended consequences of some of these interventions? And what human factor approaches may apply to making an effective alarm? Now, in this presentation today, we're going to focus on the primary question and what the evidence is to support that. So what we found is that there was a fairly large body of literature that had been performed out there, and the studies and papers and manuscripts that have been published in peer-reviewed journals fell into three major groupings. What we titled as quality improvement or bundled activities, research articles that actually directly head-to-head compared 2 or more interventions to see which were superior. And then finally, actually a very large group of papers that did retrospective analysis of both false and total alarm suppression algorithms, primarily on historically controlled databases such as the MIMIC EKG database and the University of California, San Francisco data sets. But a reasonable number of these articles were also actually tested in clinical settings, and we'll be touching on those as well. Now, one caveat I want to put out on the table for everybody to consider is that almost none of these studies actually attempted to measure alarm fatigue directly. Virtually all of these studies assumed that if we could reduce the total number of alarms or reduce the number of false or unactionable alarms, that would in fact reduce alarm fatigue. In fact, only very recently, in the last couple months, has there been published a validated tool to actually measure alarm fatigue, but it has not actually been tested alongside any interventions to our knowledge. So let's look at the quality improvement bundled activities and see what they say. Well, these are generally bundles of a bunch of different approaches. Different papers group different ones together. Some may only look at one parameter. Some may look at a series of parameters that they bundle together. These include things like alteration default monitor presets, daily electrode changes, timely discharge from a patient physiological monitor, alarm customization, education and policy changes and strategies, notification delays, and improved displays to help aid in the nurse-patient assignment process. Now, the good news about these bundled and quality improvement activities is essentially every single one that we found in the literature had some benefit in reducing alarms. And the reductions ranged anywhere between 50% all the way up to almost 90% depending on the study. So very, very effective. Nursing satisfaction workflow measures, when they were evaluated in the studies, not all did, were almost universally improved. The time spent by nurses responding to alarms improved. There was improved nurse satisfaction with the noise level in their units, and the nurses had an improved perception of the positive predictive value of the alarms, which presumably would lead to a nurse responding to alarms more quickly, realizing that they are more likely to actually reflect a true patient problem. Most importantly, is adverse events were not found to be increased in any of these studies, and those that looked at patient family perception and satisfaction showed that the perception of response time was much improved. A large body of literature, the second big group, was that of algorithm-based alarm suppression. So the majority of these studies sought to differentiate in some fashion between true and false alarms using some sort of signal processing or machine learning process, again, usually on a previously collected database, often using EKG, but also using general physiological parameters, including respiratory rate and pulse ox, etc. And several of these were actually then moved into clinical environments and tested there, and we'll talk about those. So the alarm-based suppression strategy has been very, very effective. And again, most of this has been applied to EKGs, but also to some other physiological parameters. And these include a variety of strategies, which are fairly technical, but as you can see here, they include things like relevance vector machine learning, statistical metrics extracted from signals, wavelet analysis, and something called two-time series analysis methods. Overall, as you can see, looking at the subsections under each of these headings, these were very, very effective at suppressing false alarms. How effective they were depended on the kind of EKG alarm you were looking at, whether it was asystole, bradycardia, VFib. And for the most part, they were, again, very, very effective at suppressing false alarms with minimal effect on true alarms. The one area, as you can see, that was a little difficult to get a handle on was ventricular tachycardia. In the two studies that found missed true ventricular tachycardia, it ranged anywhere between about 17% to a few percent. So this was a consistent finding that our task force found, was that ventricular tachycardia tends to be a false alarm that is a little bit harder to control compared to other false alarms on the EKG. Other strategies that have been employed besides these alarm suppression algorithms applied to these data sets include implementing alarm delays and alarm threshold adjustments. So in the studies that have looked at these, we found a couple of studies that use retrospective analysis of data sets, much like the EKG ones, where one study found that if we deployed a 19-second delay before the alarm actually was transferred to whoever was supposed to receive it, either audibly or through some sort of communication device, that you could remove 67% of ineffective ignored alarms. While a different study found that by implementing 2 to 5 second delays, you could also reduce alarms by significant amounts, 25 and 49%. Unfortunately, neither of these studies actually studied the impact of whether there were missed true alarms. A different study found that threshold and delay adjustments combined together could reduce pulse ox alarms by 60%. Unfortunately, they also found that this strategy actually would cause a certain number of true desaturation episodes to be missed. Moving these retrospective analysis of data sets into clinical studies, several clinical studies have found significant benefit. One compared various alarm statistics for both heart rate and respiratory rate alarms using general ward patients, and were able to drop alarms from 7 to 1 alarm per patient per day. Another strategy was to actually create an alarm rounds intervention where alarms were reviewed for the previous 24 hours and analyzed in order to make changes to thresholds to try to put a better fence or bracket around what was acceptable for that particular patient, and was able to significantly reduce nuisance and total alarms, but again with no missed relevant alarms. And a study in a coronary care unit that tested altered alarm thresholds as well as outcomes, including adverse events, basically didn't find any real difference in the altered alarm group, although they did have a statistically longer length of stay, which was unclear why. Another big area, another big strategy that has been published and been tested fairly extensively is actually to develop smart alarms. That is, to try to create an approach where we can integrate alarms into each other and create alarm contextualities so as to emulate how humans might classify whether an alarm is true or false. So just to give you an example, if you've got a patient who has an arterial invasive line-in where you have an arterial waveform and you've got the EKG running, if the EKG starts alarming for example, asystole, but the arterial blood pressure waveform clearly shows that the patient has a perfectly fine pulse and pulse waveform, can you use that piece of knowledge to suppress the alarm that is presumably broadcasting a false asystole? And so several strategies have been deployed. One of the studies we looked at used a fuzzy range classifier to integrate several different physiological vital signs and found a significant reduction in alarms, about 55%, although they did also find that it missed one true event, and that is probably unacceptable because true events always need to be caught. But a different study used a super alarm pattern strategy where they actually looked at co-occurring alarms that are frequently found to precede in-hospital arrest, and found that these super alarm patterns existed in 90% of arrest events, but only 11% of non-arrest patients, creating an opportunity potentially to harness these super alarm patterns to hopefully say whether the patient is really experiencing a deterioration or is not experiencing a deterioration. And again, the example I gave before was actually tested in one study where they used the arterial blood pressure waveform and pulse rate to guide an ECG alarm suppression algorithm, and found that false alarm suppression ranged anywhere between about 40% to almost 95%, depending on the specific arrhythmia they looked at. And they also wound up with zero suppression of true alarms, except for ventricular tachycardia. And as we mentioned on the previous slide, ventricular tachycardia false alarms seem to be a particularly difficult area to make headway on. Other smart alarm studies included one that classified ventricular tachycardia based on hemodynamic impact and signal processing and machine learning. They were able to maintain a 97% sensitivity while driving their false positive rate down to only 45%. Other studies combined different but related sensors under a series of scenarios to define a true alarm. That is, they integrated alarms together to create a smart alarm, and were able to increase the PPV, depending on the scenario, anywhere between unfortunately lowly 4%, but under certain circumstances as high as 84%. Other studies were successful in improving alarm PPV by creating integrated algorithms, again, that were designed to mimic how physicians and nurses make a clinical assessment of a patient. And especially contextuality is another area that has much promise. One study used contextually altered alarm settings based on whether a patient was known to be hemodynamically unstable or not unstable. And under those circumstances, they were able to either deliberately suppress or keep the alarms activated, and found that delays in nurse response were 1.7 and 0.4% respectively, suggesting that such a strategy of reducing audible alarms could be safely performed in the patient group that was considered hemodynamically stable. So sort of an overall takeaway from these smart alarm studies, of which there were quite a few, it appears that smart alarms have strong potential to reduce the total alarm numbers and both kinds of false alarms, that is the artifactual ones, as well as the ones that, while they are not artifactual, may be completely non-actionable, even though they are technically true. So what about fatigue itself? As I said back at the beginning when I started, there's only one study that we have found in the literature that has actually developed an alarm fatigue tool. And again, unfortunately, it has not actually been tested in conjunction with any of the interventions that I previously described. However, there have been a couple of studies that have tried to examine alarm fatigue, not in as much a direct way as this new tool that's out in the literature. And of course, they found what I think we would all agree are the usual suspects. They found that delayed responses went up as non-actionable alarms increased. Delays went up as total alarm numbers went up. The one study found no change in response time. But another one that was a particularly seminal piece of work by Deb et al. Found that influencing variables were not just the alarms, that alarm fatigue is a much more complicated issue than simply the total number of alarms or the number of false alarms. It includes staff type, shift, workload, number of alarms, the alarm type and the criticality of the alarm, noise levels, time elapsed between alarms, task priority, and even actually the personality type of the workers who are responding to these alarms. So what this study would call into question is this entire focus that most of the literature has had on just trying to get the alarm number down. While getting the alarm number down and getting the non-actionable alarm or false alarm numbers under control is clearly very important. There are potentially a lot of other parameters that have to do with the general work environment and workflow that also deserve attention if we really want to truly get our arms and our heads around the problem of alarm fatigue. And one particularly interesting paper that we found where they performed essentially the same survey 6 years apart with two groups of clinicians, they found that the clinician perceptions, despite the fact that all of these folks said that they felt that their institutions were doing, were putting into place interventions to improve nuisance alarms, that things hadn't really changed. So what this illustrates is despite the fact that alarm and alert fatigue have both been getting a lot of attention, we really have a long way to go in terms of actually improving the situation. There are gaps in knowledge. There's additional research that our task force has identified, including, again, the measurement of alarm fatigue. We finally have at least one tool out there that's been validated. Trying to understand how acoustic alarms can be modified to improve responses. The impact of altering alarm default settings need additional work in terms of patient outcomes. The role of alarm extenders and notification systems. Impact of false alarm suppression algorithms on reducing alarm fatigue in a direct measurement, as well as the use of other types of monitoring, such as the deployment of surveillance monitoring to general hospital wards in conjunction with or instead of telemetry monitoring. So I'm going to hand it back over to Maria, and we're going to do this little transfer back over to Maria with another quick poll question. We'd like you guys to let us know what your thoughts are. And that poll question is, my institution has initiated alarm reduction strategies in the past 2 years. So if you strongly agree with the assessment that your hospital has been doing so, please let us know. and I will hand it back over to Maria.
Thank you, Brad. I'll give it a second until we have the answers for the poll question. Okay, so it looks like a lot of people have done some work over the past 2 years, over 50%. Some people are kind of unsure, and about 22% disagree that anything's been done over the past 2 years, so we're kind of all over the place here. So that brings us to our next section, which is what can hospitals do today to improve the situation in terms of alarm management. So what Brad talked about, all of that is good stuff, but some of it's not even available in your monitoring systems. So a lot of what is guiding us is the quality improvement work, and we know that a lot of research is still needed, but what I'm going to talk about now is what can you do today given the situation. So the Joint Commission announced a new national patient safety goal in 2014, which focused on alarm safety and management. And the goal was phased in, with portions of it becoming effective in 2014 and full implementation expected by January of 2016. The new goal consists of 4 elements of performance that you can see here. We're going to go over each of these as I go through the slides on how you can do this within your own hospital. So element of performance number 1 is for leaders to establish alarm system safety as a priority. And I would consider that step 1 in any alarm management plan. Convening an interdisciplinary alarm committee with membership from nursing, biomedical engineering, IT, physicians, respiratory therapists, and others as needed to set priorities and establish short and long-term goals is the first step to any alarm management plan. Element of performance number 2 is to identify the most important alarm signals to manage. And to achieve this, you can look at either external sources of data or internal sources of data. For example, the Food and Drug Administration Manufacturer and User Database or the Joint Commission have information on which medical devices have been associated with serious events. Overall, monitors and ventilators tend to be the most likely devices to target for alarm interventions. You may want to also look at your internal risk management data to see if any medical devices have been linked to missed alarms or near misses, or talk to staff and obtain their perception of alarm fatigue. Most staff aren't even aware of the problem because they've just grown accustomed to the noise. It just becomes white noise. If possible, obtain objective data from your biomed or your IT department on the quantity of alarms. Now, the next few slides that I'm going to show you how we measure alarms at Johns Hopkins Hospital. So at Hopkins, our biomed department provides us with weekly monitor alarm data and separates the data into various categories, including alarm priority level, average alarms per monitored bed per day, and average duration of alarms in seconds. And the data shown here is giving us a snapshot of our medical intensive care unit and how they're doing with alarm management. We get this, like I said, on a weekly basis so that we can use it for comparison with other ICUs and other units, as well as how the MICU is doing. In addition, the data is further broken down on our report to show exactly what's alarming on that unit. So it can easily be seen that the arterial line systolic, diastolic, and mean alarm limit breaches are the predominant reason for monitors alarming in the MICU. So to reduce alarm burden, it would make sense to target alarm interventions towards those 3 things. Step 3 is to determine what measures you will use to reduce the quantity of alarms. Here's a few that we've used over the years, including revising our monitor alarm defaults to actionable limits and standardizing them across similar types of units, such as ICU, telemetry, pediatrics, establishing good electrode practices, creating telemetry initiation and discontinuation criteria with daily evaluation of the need for telemetry, encouraging alarm customization for patients who consistently breach established threshold limits, and assuring that staff are aware of alarms and accountable, using middleware to direct our alarm escalation plan. With any plan, though, it's a balance between alarm management strategies that decrease noise and alarm burden and maintaining patient safety. Units have to be comfortable with the plan that you put in place. Step 4 is to assure that you have an alarm management notification system in place. Now, obviously, the alarms will be heard at the primary medical device if someone's standing right next to that device. But what if no one is near the device? How will staff be notified? This is known as secondary alarm notification. It's the backup plan or the alternate means of receiving alarm notification. These are some examples of secondary alarm notifications that we've used. At Hopkins, we use a variety of these based on the type of unit. Our main campus does not use remote monitor watch except for one 32-bed high-risk adult cardiology unit. But we use all of these other methods that you see here throughout our hospital in one way, shape, or form to assure alarm audibility and accountability. Use of middleware has been a useful method for sending alarms to the right person at the right time. We've developed many alarm escalation algorithms for not only our monitors, but for other alarms such as ventilators, bed alarms, and our nurse call system alarms. The algorithm allows us to set criteria for alarm escalation. What you see here is a simplified version of an algorithm for crisis, non-crisis, and technical alarms. The reason behind the 60-second delay for the non-crisis and technical alarms is to allow those alarms to auto-correct. We found that about 90% of alarms will self-correct, or they're being caused by staff who are already in the patient room and manipulating the patient, so there's no sense in sending them alarm on their notification device. The delay minimizes the number of nuisance alarms being sent to staff, and that's why it's put in there. And as you can see, we err on the part of all crisis alarms being true, even though we know that they're not all true, and we do not put any delays on those crisis alarms. Step 5 is actually element of performance 3. Element of performance 3 of the Joint Commission National Patient Safety Goal on Alarm Management is to develop an alarm management policy. As we all know, I'm sorry, my phone just went off. I have listed, as we all know, you cannot fix problems with policy and education alone. Everyone knows that a policy doesn't fix anything. Thus, you really have to make sure that those prior steps are followed in order to reduce the alarm burden before you can put a policy in place. Key components of any alarm policy are to differentiate the types of clinical alarms and expected response, to discuss alarm notification methods, to describe who's accountable for alarm management, and to document an alarm inventory. Specific language to be included in any alarm management policy is seen here. When can alarm signals be disabled? Who has the authority to set and change the alarm default settings? Who has the authority to turn the alarm signal off? And who responds to the alarm signal and checks it for accuracy? Here's a practical example of an alarm management plan for our hypothermia machine. You can see that all of the key elements are addressed on this chart at the top for hypothermia alarms. This is how we've done this for all of our alarming devices. We've developed these charts that give guidance to the staff, and we've embedded them into the protocols. Element of performance 4 is to educate staff about the purpose and proper operation of alarm systems for which they're responsible. This should be done during orientation or on an ongoing basis. Due to the size and variety of our units, we delegate a lot of our education to our unit trainers and preceptors. And for monitors, we've developed a monitor competency checklist, which can easily be applied to any medical device. The concept of checklists are useful when you're training new people so that they don't forget the steps of how to train. And in summary, here are the 6 steps that I just reviewed with you. Engage support from leadership and an interprofessional alarm management committee. Perform an alarm assessment and try to use your own data to drive change. It's very useful to use your own data. Using rapid cycle QI approach is also very useful. Determine the best measures to reduce the quantity of alarms, and it's not always the same. It could be different. So, for instance, pediatric units are different than ICU units, so you really need to look at what types of measures are appropriate for the population being served. Identify the best methods to notify staff of alarm signals. Develop your policy to match your plan, and that's why I put alarm management policy towards the end, and provide initial and ongoing education. So at this point, I would like to entertain questions on what we've discussed so far.
Thank you, Maria and Brad. So we'll open up now to the audience. If there's any questions out there, you can simply type them into the question box to the right of your screen. We already have one question. They would like to, some of the audience members would like to have access to either a bibliography or citations for the slides. So.
Yeah, absolutely. I think, Brad, do you think the systematic review would be, that's going to be coming out soon?
Yeah, the systematic review, it's undergoing requested revisions to be resubmitted to Critical Care Medicine for publication. But Vishaka, if you think it's appropriate, we could provide the reference section of that manuscript along with the slide set. Would that be appropriate, or should we wait till it's actually published and people can see it there?
Sure. It'll take about 3 days for it to get published on our YouTube, and we can definitely share the citations as well. Okay,
great. Yeah, we will provide that so it gets up on the YouTube at the end, so folks can take an opportunity to go and look at that and see what those citations are. But again, hopefully the paper for this systematic review, and one that also focuses on alert fatigue, that is a sister paper, will be coming out probably in the journal. We're hoping end of spring or beginning of summer.
Okay. Next question. What is the approximate cost involved in alarm data collection using middleware vendors?
Well, we purchase middleware for more than just getting alarm data. It's the middleware that we use is a vendor neutral product, and so we use it for it's kind of like the bus that sends information not only about alarms. You could also send any information you want. So it's used for more than just alarm reports or getting alarm data. I can't tell you what the cost is because I wasn't the person who actually purchased it. The plan was made when we built our new hospitals here in 2012. We never had Monitor Watch here at this hospital. So we have these units that are the size of football fields. They're huge. And so we had to have a plan in place that allowed us to develop these algorithms so that we sent the alarms to the right person, whether it's the respiratory therapist or the nurse or whoever. It can go to the doctor. It can go to whomever. It can go in an email. It can go via a phone, a pager. So this was all developed and purchased by our biomedical engineering department, and we have an enterprise license to use it throughout our hospital. So I'm not exactly sure of the cost. I would think that it would vary based on the size of your unit or the size of your hospital, and also the negotiation by your your hospital finance department.
My suspicion is that it's a very cost-effective, although we don't know the exact price tag, so to speak. We've used it fairly extensively in the work that Maria's done and some work that I've been doing surveillance monitoring on general hospital wards. It allows extra levels of customization for reducing alarm fatigue and alarm, false alarms and excessive numbers of alarms, because you can build in these extra notification tweaks, for lack of a better description, on top of what is already available in the physiological monitors. So it gives you an extra tool with which to work to try to control alarm numbers and false alarms. I could certainly try to find out roughly what our hospital is spending on it, and try to communicate it back to folks if anybody's interested. But yeah, unfortunately, Maria and I just don't know what the line item cost of that system is.
Yeah. I can guarantee it's less than having a 24/7 monitor watch, because in our hospital we actually investigated doing 24/7 monitor watch, and the size hospital as Hopkins, we were going to need 80 FTEs to run a monitor watch center, and so we knew that was not going to be the plan that we could follow. So the middleware was something that we investigated back in 2010 as a solution. And it actually, to be honest with you, it has really worked very well because we use it for a lot of other purposes besides just alarm management. So it actually has been a really good decision.
Yeah. And just for reference size for folks on the call, we're a 960-bed hospital. So, 88 monitor watchers versus a 960-bed hospital. As Maria said, it clearly was the cost-effective strategy to go with.
Okay. A few questions here sort of on focusing on sort of culture and change of culture. Questions regarding, did you experience resistance with trying to limit the alarms or turn alarms down from in particular, the critical care physicians? And also, how did you manage staff expectations and changing new strategies? Speaking from a critical care physician myself, I would welcome a reduction in the alarms.
Yeah. So I was really lucky because I had the head of our medical evaluation committee. His name is Adam Saperstein. He was the person who worked with me, and he understood the concept so well and so did most of our ICU physicians. We had no trouble with the physicians. The physicians were all over it, and they were happy to decrease alarms. So I would say the physicians were not the problem. It was actually the nurses who were resistant at decreasing alarms. They said, "Oh, I'm afraid I might miss something." Well, when you have hundreds of alarms, and I'm not kidding when I tell you we had one of our ICUs had 771 alarms per bed per day. When you have that amount of alarms per patient, you're talking about a very, very noisy unit. And I remember the first time we changed those alarms, and we did it in stages. We didn't do it all at once. We did small things, small plan, do, study, act changes. And I remember the day we changed the defaults on that unit, Adam walked into the unit and he said they were afraid they were actually missing. They were afraid that the monitor wasn't connected. And they went over to make sure that the central monitor speakers were connected because it was so quiet just by making the changes to the default. So it really is one of those things that you can't do everything all at once. You have to do what staff are comfortable with. And it wasn't the physicians at all. The physicians were well aware of the problem. It was really working with the nurses. And so now we're at a point 10 years into this that we don't have any problems with our nursing staff. They get it. And actually they expect us to have, very quiet units.
Hey, Maria, quick question. I don't recall. Was there a lot of pushback from the legal department of the hospital? That might be folks to be interested in.
Yeah, there wasn't, Brad, and the reason being is actually several events led to us forming the alarm committee, and these were near-miss events, and so it was clearly found that people didn't even hear certain alarms on the unit because they were inundated with too much noise, and so they're the ones who actually asked us to start this project, and that's how our alarm committee formed in 2006.
All right. Interesting question here, integrating, I don't think this was touched upon, the impact and the role of the monitor technicians. And is there any studies looking at their role and or their staffing, 8-hour shifts versus 12-hour shifts for monitor techs?
Yeah, so I could address a little bit about that. There's been a couple of studies out there that show how many monitors a monitor tech can watch. You know, generally about 40 waveforms is about the limit. I would say on one of our units, we have a 32-bed unit that's a high-risk adult cardiology unit that we have one monitor watch 24/7 watching 32 beds. And that monitor watch also watches not only waveforms, but also watches pulse oximetry and blood pressure, art line, and so forth. So that's really at the high end. When you start talking about 40 waveforms, that's a lot. But this is an area where more research is needed, and I actually wanted to do that research, compare Monitor Watch to the middleware. Just haven't gotten around to doing that yet. That's something that I think is needed. So if anybody's out there that wants to do a good study, that is definitely something. Monitor Watches are great in that they do filter things. The problem that I have is that the middleware, you could actually write rules. Like, for instance, you have patients who toggle, like their pulse rate, their pulse oximetry maybe goes down for 10 seconds and comes back up, and then it toggles down again and comes back up. Monitor watches don't watch things in that level of detail. So what I would really like to know is what would be the benefit of having middleware with the monitor watch, because the middleware could actually alert the monitor watch to scenarios that are worth their attention and looking and taking a deeper dive into.
Yeah, certainly, that kind of analysis that Maria is describing could help make the job of the monitor watcher much easier, so they could potentially handle the workload that they're being asked to take on. Because if such algorithms could put patients into bins of this patient is behaving more unstably in terms of their vital signs, for example, than another patient, you could have, shall we say, bins of patients. The folks who are very stable, let's say a fairly typical post-op patient that needs monitoring for something versus the much more unstable patients. That way you could have some contextuality in terms of who's most likely to get sick, who's most likely to have a deterioration.
Right, depending on...
I was going to say also the monitor watchers, the issue of fatigue for them, because that's their job, is to sit and watch all these vital signs, is probably a slightly different question than the overall alarm fatigue for all the other folks who are at the bedside, because the monitor folks are really watching the physiological monitors. As Maria pointed out at the beginning of the talk, there's a lot of other alarms out there that the monitor watchers don't typically watch. The ventilator alarms, the tube feeding device alarms, the IV alarms. We tend to focus in on physiological monitors, heart rate, respiratory rate, the SpO2, but that's only a fraction of these alarms and this noise that we're trying to deal with.
And that's where the middleware comes in handy, because you can send any alarm, infusion pump, ventilator, and you don't have to send them to the same people. You could send the ventilator alarms to the respiratory therapist, and, a nutrition alarm could go to, the tech. So that's the beauty of having the middleware, that you can use it for other purposes.
Yep, much more diversity, shall we say, than with a monitor tech. I mean, monitor techs are great and do a fabulous job. Could you imagine trying to load them with all those other alarms on top of the physiological monitors? So Maria's spot on that these middleware and algorithm strategies can really help prioritize things.
Right. There's a lot of technical questions asking about whether or not there's specific companies or tools that you have that you use in your institution, and would they have access to those data?
Yeah.
That's
I don't
hard
think,
to get to each of them.
Yeah, I don't think we want to talk about any specific vendors, but if you go out and just research middleware, you will find that there are a lot of vendors out there on the market. Many of the monitor companies have their own proprietary middleware that they use, but what we did is we went with a vendor neutral vendor, so that any thing that we put in, like whether it's a GE or a Philips or a Space Labs, or whether it's a Puritan Bennett ventilator versus Hamilton or whatever. So we wanted to go with vendor neutrals. There's a lot of information on the internet that you could look for, and Biomed should be. Look, you should also talk to Biomed.
Yeah, absolutely. I was going to say a good suggestion might be, as you just suggested, Maria, is talk to the vendors of the systems you already have. They may have some of these products or some recommendations right off the bat, because unless it's been brought up as a discussion point, it may just have never surfaced.
Most people don't know to even ask the question about middleware. What happens is they just replace what they have. And if you really want to think about it, do you want ECG monitoring? Or maybe there's some other type of monitoring out there that is better than telemetry monitoring. So it's really a good time now to start thinking about, especially when you put a lot of money into these systems. Do you really want electrocardiographic monitoring, or are you looking for vital sign monitoring? And you just want to question that and not necessarily just buy the same thing that you've been buying for 10 and 20 years.
Yeah, I would argue that I think the monitoring industry, for lack of a kind of a big umbrella description, is really ready to help us drive this process to both make the environment and workplace better for clinicians, but also safer for patients. I think they've been hearing it for the last 10 years, and I think they're getting it. And I think they're really poised to help us develop solutions. But they do need to hear from hospitals around the country that they want these solutions.
Sure. And let's see, how about some of the tools, survey tools that you've presented in some of the various studies and some that you may have used in your institution? I'd like to know the name of the alarm fatigue tool and where it was published, as well as any of the other survey tools that they might have access to. I don't know if they want to maybe email you or.
No, let me get it for you right now.
I think I have it too. I just sent it to somebody at UCSF today. It's I have it, Brad. It's
Torbazeta, I think is the name, right?
Torbazeta, Torbazedeh, and it's called A Nurse's Alarm Fatigue Questionnaire Development and Psychometric Properties. It was in the Journal of Clinical Monitoring. I guess it's JClin Monitor Computers, and it was published on the 15th of November. So if anybody needs it, I can send it to Vishaka, and she can certainly make it available.
Also, the reference will be in the paper, the systematic review papers that will be published in Critical Care Medicine over the next couple of months. So it'll be there as well.
This particular paper came out of Iran. It was a group of students. It looked like it was a school that was working with students on a alarm fatigue questionnaire. So it was actually quite good.
Right. We're hoping to see some studies in the near future where people actually use it alongside to measure the effectiveness of an intervention. Again, this study was a tool validation study. It didn't actually connect it directly to an intervention as a measure of the effectiveness of that intervention.
Right. All right. I think we get time for maybe one or two more questions. Before we get to that final question, would it be possible for the audience maybe to send their individual questions to either of you via email or some source offline, if that would be all right? Because there's a vast majority of questions ranging from specifics to vague, and there's no way we'll get to them all, and I hate that there's a lot of questions.
Yeah, I think Vishaka, are the emails for both of us in the packets that we can, people email me all the time, and as I'm able to, I get back to them, usually within a week or so.
Sure. We can actually put your emails even with your, even on the PowerPoint PDF. Yeah. So in that way, you can access it there as well.
Yeah.
Great. All right.
Yeah,
So
Doc, we could just add them to the title slide where our names are.
Yeah.
Oh. All right. One final question, kind of a loaded question, I think. Do you think that alarms are fundamentally obsolete and need replacement by more sophisticated clinical decision support?
I'll defer that to Brad.
Use the term obsolete. I think the way we've done them for the last 50 years or so, in that sense, they are. But I think basically the modalities that we are measuring, we need to be able to integrate them and make them contextual. So I would say if the question is asking, well, is measuring the heart rate or the SpO2 not valid? I think that is incredibly valid. It's what we do with that information. So having them as standalone individual parameters that have no context and have no cross-referencing to each other, I think is archaic. And I think I hate to overuse the term smart alarm because we use that very frequently in our society to describe anything that's new and fancy, like smartphones, et cetera. But I truly think that the integration of all this vast data stream that we are trying to swallow on a daily basis, to distill it down into the real question, who is getting sick and who is not, I think is the way of the future.
Yeah, agree.
Well, it certainly seems to be a vast majority of yet to be determined information on this topic. It's certainly been an eye-opener for me, and I'm sure that the audience seems to be very keen on this, and I'm anxiously awaiting all of the new studies that will come out looking at this and the new technology that will be spun off from this. And I just want to thank Maria and Brad for their expertise and their time to present to us today. Again,
go
ahead.
Joe, I just want to say one last thing. As part of our systematic review, the reviewers asked us to do an update on our systematic review, and just in the last year, we found an additional 800 citations that related to this subject just in the last year, as compared to our previous systematic review, which covered a 20-year span that had about 4,000 articles. Just give folks a perspective on how this is really, as you just described, is an area where there's a lot of stuff developing.
Great. We'll look forward to it. Just a reminder to our audience members that today's webinar will be available on Society of Critical Care Medicine's YouTube channel at youtube.com/SCCM500, and it'll be there within 3 business days. Also, I want to extend an invitation to all of us to please join us on April 26th for the second half of this presentation from 1 to 2 p.m. Central for the webcast series on approaches to manage alert fatigue and suggestions for appropriate metrics. At this point, I'd like to close out and wish everyone a great day.
Thank you.
Thank you.